Hello, and welcome to another episode in our Smarter in Minutes series. I'm Dayna McManus. I'm a pharmacy supervisor for infectious diseases at Yale New Haven Hospital in New Haven, Connecticut. I'm joined by my colleague, Dr. Natasha Bhuyan, who's an assistant clinical professor of family, community, and preventative medicine at the University of Arizona in Phoenix, Arizona.
Hi, Dana. Thank you for having me.
Thank you for being here. Over the next few months, we'll be posting a series of these short CME certified videos focused on the management of patients with COVID in the outpatient setting. This activity is jointly provided by National Jewish Health and Bonum CE. This program has been supported by an educational grant from Pfizer. Please be sure to let us know who you are and complete the pre-polls in the tweets below or using the QR code shown on screen. Today, we will be talking about Paxlovid in the outpatient setting for treatment of mild to moderate COVID. Paxlovid is a combination oral protease inhibitor which contains two components, each with different mechanisms of action. The first component, nirmatrelvir, is given in 300 milligrams, and this is the main protease inhibitor against the SARS-CoV-2 virus. The other component, ritonavir, is given in 100 milligrams. It works to inhibit cytochrome P450-3A4. By inhibiting this enzyme, it prevents further metabolism of the nirmatrelvir component, which allows for it to reach higher therapeutic concentrations that are needed to treat COVID. It is important to note that there is dose modification required for patients with renal disease. And because of that, Paxlovid is available in a lower dose formulation for patients with renal impairment. Specifically, patients with an estimated GFR of 30 to 59, we use 150 milligrams of the nirmatrelvir component and 100 milligrams of the ritonavir component. This is still dosed twice a day, like the normal formulation. For patients with an estimated GFR of less than 30, Paxlovid is not recommended. Paxlovid was recently FDA approved on May 25th, 2023 for mild to moderate COVID-19 in adults who are at high risk for progression to severe disease, including hospitalization or death. It remains under an emergency use authorization, or EUA, for treatment of eligible children ages 12 to 18 and weighing greater than or equal to 40 kilograms. Currently, it is not FDA approved for any other indications, such as pre or post-exposure prophylaxis. As I mentioned, it's dosed BID, and it is taken for a 5-day course. It can be taken with or without food, and it comes in blister packs with the two different components for ease of administration. The renal dose adjustment also comes in this blister pack with the lower doses. Now, Natasha, can you tell us about the trial that led to this FDA approval for this indication for Paxlovid?
Yes, Dana, the pivotal trial for Paxlovid was the evaluation of protease inhibition for COVID-19 in high-risk patients, also known as EPIC-HR. This was a randomized, double-blind, placebo-controlled clinical trial comparing Paxlovid and placebo. About 2,200 symptomatic, unvaccinated adults with confirmed COVID infection were enrolled. About half the group got Paxlovid, while the other half were in the placebo arm. Treatment was initiated within 5 days of symptom onset or earlier, and dosed every 12 hours for 5 days. The primary endpoint of this trial was COVID-19 related hospitalization or all-cause death through day 28 in patients receiving treatment within 3 days after symptom onset. A secondary analysis was also done looking at the same parameters in patients that received treatment within 5 days after symptom onset. About 1,300 patients were in the modified intention to treat population. There was an 89% relative risk reduction through day 28 for the primary outcome, and an 88% relative risk reduction for the secondary outcome. And the viral load was also lower in the Paxlovid treated group at day 5 compared with the placebo. So Dayna, we know that Paxlovid is efficacious in the patient population. What do we know about the safety of this treatment?
Well, there were a few safety concerns that were reported in the EPIC-HR pivotal trial. The incidence of adverse events which emerged during the treatment period were similar in the two groups. When looking at any adverse event, 22.6 occurred with the Paxlovid group and 23.9 with the placebo group. So very similar comparison between the two. When looking at serious adverse events, only 1.6% occurred with Paxlovid versus 6.6% that occurred with placebo, so slightly higher with placebo. And then when looking at adverse events that led to discontinuation of the drugs or placebo, this occurred in 2.1% with Paxlovid and at a higher rate, 4.2% with placebo. Of note, dysgeusia was the most commonly reported side effect with Paxlovid, occurring at 5.6% versus 0.3% with placebo, followed by diarrhea, which occurred at 3.1% with Paxlovid and 1.6% with placebo. So those are the two most common side effects that were seen more commonly with Paxlovid than placebo. Given that this product is co-formulated with ritonavir as a pharmacokinetic booster, there is potential for significant drug-drug interactions, particularly with very commonly used medications. Some examples include statins, calcium channel blockers, anti-epileptic medications, and other CYP3A4 substrates. For many medications, dose adjustment or temporarily holding the medication and doing clinical monitoring is all that is needed during the 5-day period when Paxlovid is given. However, for some medications, such as statins like simvastatin or lovastatin, Paxlovid can be started 12 hours after the last statin dose. And these medications then can be held throughout the course of Paxlovid and for 2 days after completing Paxlovid dosing, because the effect on CYP3A4 continues for up to 48 hours, typically following stopping of the drugs. There are some medications also that have interactions that are so severe that Paxlovid has to be avoided altogether. Examples of these medications include rivaroxaban or salmeterol. Patients that are on contraindicated CYP3A4 inducers with long half-lives, such as phenytoin, phenobarb, or carbamazepine, should avoid Paxlovid altogether. Because of these drugs' long half-life, they cannot be stopped in order to take Paxlovid in a timely manner. And the washout period is so long that just the 5 days is not enough. We would be outside of the window of symptom onset when Paxlovid would be indicated for us to be able to hold these medications before starting Paxlovid. So an alternative agent would need to be utilized in a patient that is on one of these medications. In addition, it's important to note that Paxlovid is also not recommended for individuals with severe hepatic impairment. And as I mentioned previously, remember that dose adjustments are necessary for renal impairment, but if someone's estimated GFR is less than 30, then Paxlovid is not recommended. Now, Natasha, can you tell us a little bit more about some of the additional studies that were completed about Paxlovid?
Yes, Dayna, Pfizer conducted 2 additional EPIC trials with Paxlovid in standard risk patients and for post-exposure prophylaxis. This was initiated around August and September of 2021 and was completed during the peak of the COVID Omicron wave. In this trial, compared to placebo, risk reductions of 32% and 37% were observed in adults who received Paxlovid for 5 and 10 days, respectively, to prevent infection. These results, however, were not statistically significant, and as such, the primary endpoint of reducing the risk of confirmed and symptomatic COVID-19 infection in adults who had been exposed to the virus through a household contact were not met. But the safety data was consistent with other EPIC trials in more than 3,500 Paxlovid-treated patients and post-marketing safety surveillance. This standard risk patient trial was terminated due to low rates of hospitalization and death. And Dayna, how has this treatment played out in the real-world settings?
Well, there was a real-world evidence trial that was conducted at the Mass General Brigham healthcare system. It was a population-based cohort during the Omicron era. It looked at just over 44,000 non-hospitalized adults, and the majority of these individuals were vaccinated. The percent vaccinated in the trial was 90.3. They were adults over the age of 50 with confirmed COVID. And the primary outcome of the trial was hospitalization or death within 14 days of diagnosis. 28.1, or just over 23,000 patients, were prescribed Paxlovid in the trial, versus 71.9%, just over 32,000, were not. Those prescribed Paxlovid, not surprisingly, tended to be older, vaccinated, and have more comorbidities than those that did not receive Paxlovid. The composite outcome of hospitalization or death was seen in 69 individuals, 0.55% with Paxlovid, versus 310 individuals, 0.97% without Paxlovid. Hospitalization alone occurred in 40 individuals, 0.66% in the Paxlovid group, compared to 232 individuals, or 0.96% in those not prescribed Paxlovid. The adjusted risk ratio was 0.60, and death adjusted risk ratio was 0.29. The observed risk reduction was found to be greater among unvaccinated patients and obese patients. And that's not surprising, since we know those are some of our highest risk individuals. The overall risk of hospitalization was already low at less than 1% following an outpatient diagnosis of COVID-19, but this risk was lower in those that were prescribed Paxlovid. So Paxlovid was associated with an increased protective activity, especially among those with a BMI of 30 or higher, compared with non-obese individuals. And that was statistically significant difference with a p-value of 0.007. So after covering so much detail, Natasha, I'm hoping that you can help summarize some key points for our audience and learners to take away, please.
Yes, the key takeaways from today's discussion are: Paxlovid was approved on May 25th, 2023 for the treatment of mild to moderate COVID-19 in adults who are at high risk for progression to severe COVID-19, including hospitalization or death. It is available under the emergency use authorization to treat children ages 12 to 18 and weighing at least 88 pounds with the current diagnosis of mild to moderate COVID and who are at high risk for progression to severe COVID-19, including hospitalization or death. The EPIC-HR trial showed an 89% relative risk reduction through day 28 for the primary outcome and an 88% relative risk reduction for the secondary outcome. The incidence of adverse events that emerged during the treatment period in EPIC-HR was similar in the two groups. And additional real-world evidence shows Paxlovid was associated with increased protective activity, particularly among older adults and people with obesity.
Thank you so much for joining us. Please complete the post polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME. Click like and follow for more social media based CME from Bonum CE.